Okay, so let's jump in. Basic fundamentals. A quantitative EEG map is essentially taking the raw data and processing it through a fast Fourier transform so that we can understand the different wavelets and the quantification of them. And so the EEG on the left is what I call the seminal text. That is the Sanskrit, right, or the first writing.
Pali.
The quantitative EEG, what's that?
The Pali.
Yeah, the quantitative EEG is a translation. And the reason I use this analogy is because the seminal text, the raw data, is absolutely the most rich, the most full of meaning. There's many things that you can read from the raw data that you can't read in the map data. But we have to start with a basic translation. We all do, right? Because we can't read Sanskrit right out the gate. We have to understand what it means first. And so this lecture is largely about how we process the raw data, moving it into this and what it all means. So in the beginning, right, there are infraslow frequencies. Infraslow frequencies are frequencies that are beneath 1 hertz, right? They're also called slow cortical potentials. And essentially, they last anywhere from 3 milliseconds to several seconds, but they're very slow frequencies. And the negative slow potentials are about excitatory mobilization. Inhibitory positive slow potentials are about inhibition. And so what's happening with slow cortical potentials is the depolarization of large cortical cell assemblies. So hang with me here. This is the most texty slide that I have. But this is the very first frequency that our quote-unquote brain begins to emanate. Within the first trimester of life, the reptilian brain is formed. And during that first trimester, we have pretty much a gelatinous blob that is our brain. And the brain is in large part glia. Glia is a Latin word for glue. And glia is the stuff between neurons. What glia do is they are responsible for the blood dynamics, the hemodynamics in the brain, and this is where we see blood sugar or glucose metabolized, okay? And so the glia is thought of as a scaffolding of the brain. So we're not even at neurons yet, we're at all the stuff between the neurons, and there's 6 different types of glia, 6 different types of glue. There's microglia and there's macroglia. Microglia are thought to be scavengers in the brain. And then of the macroglia, there's these types here. Well, there's microglia, which is actually this one little blue guy in the middle at bottom. So top left, ependymal cells, those are on the lining of the ventricles within the brain. And what they do is they create the cerebral spinal fluid. And it's the cerebral spinal fluid that waxes and wanes up and down the spinal column and essentially washes our brain. Particularly at night, it's thought to remove old antibodies and things that aren't needed anymore. Oligodendrocytes, that's your myelin sheath. The myelin sheath is a lining that covers the axon and allows for conductivity, right? So it allows for that connectivity to happen, for firings to occur. A lot of movement disorders are a breakdown of the oligodendrocytes in the brain, like Parkinson's. Astrocytes, those are named after a star, Astro, and those are what is responsible in the EEG for the emboldening, the shifting of sodium ion and calcium ions. And so the activation that we talk about in the induction of neuroplasticity and the use of stimulation largely involves these these glial cells. And then microglia are kind of like little scavengers in the brain that run around and gobble up stuff that is unnecessary and transmit waste out of the brain. And then on the peripheral nervous system, Schwann cells and satellite cells are both part of the spinal cord and the peripheral nerves. Right? So we don't see them as much in the brain. And on the right is a picture of slow cortical potentials. And so a slow cortical wave is something that you can't track generally in a raw EEG. It is so slow and so large that it's indicating a different thing. It's not the firing of a neuron like most of the other frequencies. It is the hemodynamics of the brain that have to do with the metabolization of the blood glucose. Slow cortical potentials. So everything beneath 1 hertz. Everything beneath 1 hertz. So 0 to 1 hertz. It could be 0.14 hertz. So for instance, the parasympathetic nervous system, according to blood oxygen level determinant studies, oscillates at 0.14 to 0.4 hertz. What that means is it will take anywhere from, I don't know, roughly 10 seconds to 2 seconds for an entire cycle of the parasympathetic nervous system frequencies to oscillate. Okay? But let's get into some of the more familiar frequencies. So first and foremost, or secondly, delta. Delta is 1 to 4 hertz, 1 to 4 oscillations per second. Delta is a frequency that is one of the first frequencies that we emanate. It happens within the first trimester of our life that we're beginning to produce delta. And so we know about the glia, the glue, the stuff between the neurons. What delta allows for is delta allows for neurons to grab onto glia like guide wire and build long fibrous white matter tracts across the brain. And those long fibrous white matter tracts make up the basic resting state networks of the brain. So in an analogous sense, think about a string on a guitar that plays a low tone. The longer the string, the lower the pitch. What's really miraculous about delta and theta, but we'll focus on delta, is that it makes these intra or interlobule tracks. And this is during a process called migration in the brain. And migration is happening all the time, but it's really robust, of course, when we're in utero, when we're developing, and up until about 2.5 years, we're continuing to potentiate and continuing to grow in terms of all the potential neural connections, with some pruning, but for the most part, we're continuing to proliferate all the different possible connections. And so in the beginning, there is delta. Delta is the heartbeat of your mother when you're in utero in terms of the rhythm. Delta is ocean waves. Delta is tribal drums. Delta is something that we share with 2 million years of ancestors that are reptilian in origin, if you will. And so delta is a fundamental frequency for evolutionary purposes. And the brain grows like an onion. And so what works isn't thrown away, right? Nature does not dispose of what has utility. And so in this case, the reptilian brain, which is responsible for things like homeostasis, arousal, reproductive drives, instincts, activation, the basics, those are all coming from the core structures of the reptilian system, which are the cerebellum and the brainstem and some of the most basic subcortical structures of the brain, like the pons and the thalamus. So by the first trimester, the reptilian brain is complete. What's interesting about the reptilian brain is that we actually evolved from the turtle. I know that sounds bizarre, but that's from Stephen Porges's polyvagal theory. And the mechanism of sympathetic arousal that we've taken from this stage of our evolution is the mechanism of freeze, right? And so you all know that in sympathetic overarousal, it's fight, flight, or freeze, right? Fight and flight are actually a higher level order of sympathetic arousal. Freeze was the first thing that we learned in our evolutionary trajectory. And that's dominated by something called the subdiaphragmatic unmyelinated vagus nerve, right? So hang with me here. I'll get back on track. But the vagus nerve is this big chunky nerve that's the 10th cranial nerve in the brain, right? And I'm pulling on Steve Porges's polyvagal theory here, but it does play in. So the vagus, it innervates all of the organs within our trunk. But from the diaphragm under, it doesn't have a myelination for conductivity. And it's that portion of the vagus that makes us freeze. And so the freeze response is something that you see in cases of intense trauma, particularly when it's happened at a very young age and the individual has had to learn to dissociate from the thing that's happening, be it abuse, be it molestation, or other terrible things. Freeze is also something that you see the catatonic schizophrenic do as well, right? And so there's a linking all throughout the development of us with not just nature, i.e. genes and hereditary, but also nurture, right? And so the environmental influences, how we grow up, things like that. And so it is this part of the brain that allows us to think in the present. It is the reptilian brain that allows us to be here and now. There's a further lecture that draws on a deeper psychodynamic theory of what's happening when we see aberrant delta, high amplitude delta activity, when we cannot explain where it's coming from. Yeah.
Like you.
And so this is just a basic diagram of some high density network nodes in the brain and those long fibrous white matter tracts that I was talking about. So if you think about the beginning of a house, like the first architectural sketch, that's what we have with these fundamental nodes and connections in the brain. And the more densely packed the network node, the more important it is for neural connectivity. And so when I say densely packed, I want you to sort of envision the map that you find in the back of an airplane seat that has all the airports in it, right? All the airports speckled all over the country or all over the world. The high density network nodes, they're akin to Los Angeles, Washington, D.C., these major international hubs where every plane flies in. And so the high density network nodes, for instance, the anterior cingulate, the posterior cingulate, the hippocampi, they are regions where lots and lots and lots of networks cross or transgress through. And so anyway, slow cortical potentials are the frequencies that are sub-delta, but they do weave into delta later on. So healthy delta, right? In a normal healthy adult, delta happens during deep dreamless sleep or slow wave sleep. So as we descend into sleep, we go into non-rapid eye movement 1, 2, 3, and 4. And there's a series of progressions that we'll discuss later on that happen when we fall asleep. When you are at the bottom of your sleep cycle, absolutely zonked out, conked out, unconscious, as an adult, you're in a delta rhythm. And delta, as we know from looking at babies and early development, delta is responsible for neurogenesis and for angiogenesis, right? Delta is that which allows for plasticity in the brain. And so when we're asleep, it's highly restorative. It's in slow wave sleep that we're creating new neuronal chemicals, we're synthesizing neuronal proteins, we're regenerating, we're rejuvenating. This is where growth hormone is developed and distributed. And this is also when the body is doing some repair work. So the body is healing, for all intents and purposes, when we're creating delta in sleep. Now, what we're interested in, of course we're interested in healthy delta, but we're also interested in pathological delta, right? And so that first map that I showed of the quantitative EEG is something where there are columns and there are rows. Let's see if this next picture. Okay. For a second, I'm just going to reference this map because there's a handful of quantitative EEG databases. This is a picture from something called NeuroGuide, but for all intents and purposes, they're largely the same. And my lectures use these pictures to describe what I'm talking about in image form. And so, so when I'm talking about high or low delta, what I'm referencing is how many steps or standard deviations we are away from the norm. And so if you can see my arrow, yeah, this little scale down here at the bottom is a scale of steps or standard deviations away from the norm. So the white part here, when we see white within a head, it represents that that range of normal in terms of the power of the frequency. So literally, how big is that frequency? Now
you mean in amplitude?
In amplitude, yeah. And so amplitude is microvolts squared. Magnitude is just microvolts. But essentially power. We're going to use the term power to stay neutral. And so in this case, we have columns and we have rows. The columns show delta, theta, alpha, beta, and high beta. And the rows show different metrics that we're going to discuss during this lecture. The top two metrics are what I'm focusing on right now when we're talking about power. And as we can see in the very top leftmost head, delta is 4 z-scores or 4 standard deviations higher in amplitude than is normal for a person of this age. Okay? And so that's what quantitative EEG is all about. It's a point of relativity, essentially. What is normal and where do you fall within that normal range? Not every tree stands straight. And that's one of the things that I tell folks quite often in this field, because my goal and your goal is not to make people normal, but is to address the issue. Mm-hmm. And so to align the symptoms with what they're showing in their data, and in this case in their quantitative EEG, is paramount to their recovery or their healing. Okay, so when I talk about high voltage, I'm talking about red. When I'm talking about low voltage, I'm talking about blue. So that said, unhealthy delta. Let's go to high delta. When we're dealing with high amplitude delta, that is real, because there's lots of imposters, and we're going to cover those. It's quite significant. It's nothing to be easily dismissed, because what it indicates is white matter damage or white matter abnormality within the brain. When we're talking about white matter, we're talking largely about subcortical matter within the brain, which means that that person, if it's some white matter damage, they've had to get a pretty good hard whack on their brain. If there was a car accident, if it was a TBI from a sports accident, something like that, then we would expect to see some excessive high amplitude delta if it was fairly severe. And there would be functional deficits, there would be cognitive deficits. And so real delta will make itself known.
Steve, question, does your software or your equipment identify the frequencies for us?
Yes. Okay. Yeah. And so when I say neurodevelopmental problems in terms of high amplitude delta, that is indicative of white matter abnormalities. Okay? And what do we see white matter abnormalities in? We see white matter abnormalities in kiddos that have a genetic thing going on, right? So a spectrum-based disorder, something like that, where there's literally a wiring difference in the brain. Okay? And there's variations on that theme. I mean, like cerebral palsy. But generally speaking, it's a noticeable disorder. Developmental trauma, so that one's a little bit more interesting. This isn't as well researched and it's not as widely written about, but when little kiddos at a very young age are subjected to different forms of developmental trauma, be it, again, abuse, neglect, molestation, witnessing of violence, exposure to drugs and alcohol, an unstable home, I believe that there's a presentation of delta, and I believe you tend to see it centrally because it's a limbic delta as opposed to a damage-oriented delta. That is to say, the thalamus, I'm going to go down the rabbit hole, the thalamus can gate as low as 2 hertz, right? So it's a subcortical structure that can push out a very slow frequency. We are adaptive, meaning we're trying to survive foremost, right? To succeed secondarily, but initially to survive. And so young ones adapt. And if what you have in your toolbox is delta as a baby, and you're in a dangerous environment, that's the thing that's going to get enhanced. So you may just see it in an adult's EEG, and it might not be a TBI. It might be something that's earlier, right? Something that's from early life. High delta can indicate sleep dysfunction, but that's actually not something that I would typically even put in this slide. Sleep dysfunction has so many different pathologies and so many different presentations. Sleep dysfunction primarily, or I should say when it concerns delta, shows up in a deficit of delta, okay? And it's one of the profiles. Because delta is deep dreamless sleep. And if you think about it, delta also is the frequency that we emanate when we are in infancy, when we're being held, when we're being rocked, when we're being nursed, when we're being taken care of. If there was, an inability to let down or relax, it may show up in a deficit of delta. A couple more pieces here. High delta can show up in toxic encephalopathy and metabolic encephalopathy. But again, it's a high level of toxin exposure that you're dealing with at that point. And that person, chances are good, needs to be referred out. So I think the thesis to all of the high delta stuff is question it, and if need be, refer out or get consultation if you're concerned about it. Yeah.
What about things like demyelinating disease and so on?
Yep, we're going to get to that. Demyelination, one of the things we see often is gamma, high amplitude gamma with demyelination. So low delta. What about if someone has blue delta in their brain? Yeah.
When you say refer out, you mean like to a medical professional?
Yeah, to a neurologist. Yeah. And same is the case with focal delta, which I'll talk about here in a sec. So low delta, when you see blue delta, it can indicate old or repetitive head injuries. So you'll see that in folks who were like, oh, in 1972, I was in a car accident and I was in a coma for 10 days, and can you see head injury in my EEG? Or in someone that is an athlete and has had a series of repetitive head injuries, and essentially my theory on this is that the brain, if there's an axonal shearing, there's actually like a scar tissue of sorts that forms, and it prevents the easy conduction of EEG through the cortical tissues. It's not as easily seen through the different layers of the meninges at that point. Chronic migraine, sleep dysfunction, poor circadian rhythm, and then this last piece, when we see a low voltage brain, it doesn't mean that that person's an alcoholic, but it can indicate a mutation of the GABA A receptor sites, and that's the fourth gene. And in that case, what the individual cannot do is they cannot metabolize GABA, which is an inhibitory neurotransmitter, which we take on when we drink alcohol or when we take a benzo. And so when you see a low voltage brain, particularly erring towards low voltage delta and theta, those people are more likely to be addictive personality types.
And stim can actually do quite a bit for addiction. Did I hear that correctly?
Yeah. Yeah, that's a whole nother topic, but absolutely.
Okay.
Depends on, lots of pieces, but yeah, addiction is within our wheelhouse for sure. And so let's talk about how to redraw EEG. So some of you are as green can be, which is lovely. This is delta. This is some real big delta. So I'm going to pull out the easy in-your-face cases of things. Now, how do we know it's delta? Well, remember, delta is 1 to 4 hertz or 1 to 4 oscillations per second, right? Each second is going to be marked here by the dark blue lines. And so our job in reading EEG is counting and recognizing patterns. And so delta is 1, 2, 3, 4, right? You can see it here too. And basically what you'd want to do is imagine the repeating rhythm, right? Sometimes it's not continuous. There's moments where, like for instance, it fades out a bit at the end over here. But you can see that we have approximately a 3 to 4 hertz rhythm running through the EEG. Does that make sense? Okay. This is a 13-year-old boy who was crushed in an elevator and was without oxygen for 8 hours. That's some intense cases. So you see delta in cases where there wasn't enough oxygen provided to the brain, hypoxia and anoxia. right? Those are cases of brain damage that was caused by birth injuries. If the kid was in the birth canal for too long, they didn't get enough oxygen-rich blood to their brain. And what happens, then we have a scattershot injury where little bits of brain tissue die, right? Okay. And so this is the translation of the seminal text into the translation, into the book, essentially, into the map, right? And so you can see, oh, that high amplitude delta translates to 4 standard deviations, more delta frontally, and in the posterior temporal lobe than we anticipate. And this kid also has some theta woven in there, right?
Super quick, sorry.
Please.
So we know that there's delta, because we count them between the things, right? 1 to 4 oscillations per second. How do we know if it's high or low?
So in this case, for each
I have a question.
Sure.
So would you
This is delta, and this is what it looks like in a linked years montage. And so in this person's case, or in another case, this is a focal delta, right? And so in that case, it's showing up at T5. But you notice it doesn't say T5 LE. We don't have the linked years montage anymore. Now we have CSD. That's called an average montage. It's a Laplacian montage or a current source density montage. And so it's one of the ways that we can identify the home of the bad guy, right? Where does that delta live? And focal delta indicates there is the rotten spot in the brain. That's where we have the dead tissue. That's where we have the ischemia, the infarct, the lesion, the tumor, the place where the person was deprived of oxygen. What that will generally look like in a map is something more like that. So this is,
I'm sorry, to take the focal delta, at that point you have to change the electrodes in order to identify the position? Or what?
no. After you gather the data, you can just change the montage one click.
Okay.
Yeah. And so this is an example of focal delta. Yes.
So the deeper areas of the brain, they're harder to pick up based on EEG.
Absolutely.
And it's the deep parts of the brain that are most affected by hypoxia or anoxia.
Depends.
Well, my understanding is like if you're anoxic, it's gonna hit the deep parts of your brain before it moves out. So I'm just thinking we would probably not see a lot.
Most of the hypoxia and anoxia cases that I've seen have shown cortical damage, but it's, I've also had brainstem strokes that have come in and things like that. It's another question. It's another conversation for another time. But you're right. So the spatial resolution of EEG is more limited than the temporal resolution of EEG, and there's ways to find where things are located spatially.
Okay.
It's a little bit more advanced. We use independent component analysis to go there, but it's something that we'll certainly expose people to this week. So this is a good example of a pathological low voltage delta. Okay, this is actually an older man who had a car accident as a young man, and he came in and he said, do I still have a head injury? And in this case, what we're seeing is a low voltage profile. And there's a typo there. Yeah, I have a bad E key right now that's not working very well. So theta. Theta is a frequency of 4 to 8 hertz or 4 to 8 oscillations per second. So delta was 1 to 4. Theta is 4 to 8. Theta is a frequency that we hang out in childhood. Okay? And so from the ages of 8 and under, we're spending more time in theta than most of the other frequencies. Theta, like delta, is neurogenerative. Theta is responsible for the creation of new neural pathways. It's a frequency that allows for a high degree of neuroplasticity, and in that regard also makes for a very malleable time in life, right? A time where we're easily influenced, right, for better and for worse. In the healthy adult, we generally see theta in rapid eye movement sleep, and in cases of trance or hypnagogia, generally when we're falling asleep, we start to produce a central theta frequency, which is called a V wave or a vertex sharp wave. But you don't want too much theta as a healthy adult in waking state. Because it's a frequency that comes from the limbic structures of the brain. And so the limbic structures of the brain, things like the thalamus and the basal ganglia and the nucleus accumbens, are the old mammalian brain. And so it's the second layer of that onion. And so now we're drawing to other vertebrates and other mammals. And this part of the brain allows us to think into the past and into the present. So now we have the ability to reflect back. It's the limbic structures of the brain that also allow us to love and allow us to grieve. And so these fundamental structures of the brain are that which fostered the survival of a species through the love of mother, right? Very interestingly. Theta is also seen, although not as easily in humans because it's subcortical, but in hippocampal structures in the making of memory. And so memories are thought to be a synchronization of theta and gamma. Theta is not necessarily a bad thing when you see it in an adult's EEG, because in my opinion, it indicates that that individual has the ability to self-soothe, to relax, they can be chill. They're generally not racked by anxiety, all other things being normal. But excessive theta will look like an attention issue. Okay? So excessive theta as a frequency that we dream in will create inability to focus, inability to concentrate, inability to sequence tasks, inability to get things done. You're in reverie, you're in daydream, you're in fantasy, you're in hypnagogia. Now that's really useful when we need to believe in Santa Claus and the Easter Bunny and the Tooth Fairy, when the world is coming into formation and that magic is a part of the process. It's what makes children starry-eyed. However, if it hangs out for too long, it indicates that we have a system that's not maturing, and that has a lot to do with something called alpha peak, which I'll get to in a moment. But theta being what it is, generally will indicate gray matter damage when you see it in the adult's EEG, or a strain of a attention deficit disorder.
Do you see what's there with kids on the spectrum?
Yeah, I mean, theta and delta, yeah.
They
Yeah.
have low theta who has theta when they don't have any imagination. They're super aroused and sensory.
Yeah.
I've tried some things for stuff with them, and they have a lot of it was really helpful.
So I just talked about autism for a moment with white matter abnormalities.
Sorry.
No worries. One of the things to maybe hang on to a bit is the frequency is it can be in part the adjective that's used to describe the individual, right? And so what that person is showing where, at what age, is very important. Theta, what is theta? Theta is foggy, groggy, daydreamy, in a haze, not here, not present, not with it, not pulled together, right? And theta can also be highly creative. I mean, it really is an unconscious frequency, and so it is a frequency where, in my opinion, magic lies, and that's another lecture. It's a lot more fun. But for now, we're being empiricists and scientists, and so focal theta especially is going to represent an issue with the gray matter of the brain, with the bark of the brain, right? Low theta, a deficit in theta, often means there's a white knuckling that's occurring. The individual has a hard time letting go, letting down, relaxing, self-soothing. They may have a hard time falling asleep. They may have a hard time staying asleep. So both delta and theta are frequencies of different realms of the unconscious. From a scientific perspective, even from a scientific perspective, different realms of the unconscious. Theta we see in rapid eye movement, sleep, but then we also see it show up in NREM1 NREM2, and NREM3. So as you are falling asleep, you make midline theta. Theta is seen in nursing infants as well. Right around 6 months, they start to produce theta, and it's called hedonic theta. Hedonic theta, like, oh, that's so good theta, like hedonism theta. And so theta has been linked to theories that during nursing, the infant is bringing up the gestalt, or images, right? So theta's been linked to internal imagery, the mind's eye. Focal theta. Now you'll notice again that I've just switched to a montage, right? Or the letters on the second half of this spectrum say CSD. So I've switched to what's called a Laplacian montage, which is an average montage. For the time being, that's all you need to know. But what it allows for us to do is to see where things live. And I've spotted this theta. And how do we know that it's theta? Well, if we count how many bumps in a second, I might have actually pulled here 1, 2, 3, 4, 5, 6. There's probably 8. 1, 2, 3, 4, 5, 6, 7, 8. So it's arguably a slow alpha, but I'm not going to get into the nuances. So right now we have a focal theta. Focal theta can indicate ischemias, oxygen deprivation, cerebrovascular issues, and post-concussive injuries. With age-related cognitive decline, you're going to find that very often these individuals, particularly if they have heart issues or vascular issues, the posterior temporal lobes are the most easily compromised, okay? And that's where you're going to start to see a slowing of their alpha, which will generally show up in a theta range, right around to 8 hertz, okay? Or lower. This is an individual that is showing excessive high amplitude theta, as we can see. And this is a good map to explain relative power for a moment. This is a 50-something-year-old man who has the IQ of about a 5 or a 6-year-old. And so what's happening is that his processing rhythm, right, which is called the alpha peak, is actually slowing down into the range of theta. Alpha is naturally 9 to 12 hertz, but it can slow down, right? And so in this individual's case, what we're seeing is a person that's operating at the speed of a child, even though he's a man. The absolute power row and the relative power row, when I describe them to people, I'll often cover up one and then cover up the other. And so let's just focus on the very top row for a second, and I'll try to explain this principle. Some of you know of it, and some of you don't. So, so when we're looking at the absolute power row, we are taking the individual and we are putting them up against an average of other individuals their own age who are quote-unquote normal, meaning they don't have any physical pathology, they don't have any psychological pathology, they have a clean bill of health. And then what we're seeing is where they are deviant. And so in this person's case, we say, okay, so you have 2 to 2.5 standard deviations, or z-scores, more delta than the average bear, right, your own age. You have 4 standard deviations more theta. You have 1.5, roughly, standard deviations more alpha. And you have 1.5 to, if we're going into this yellow, 2.5 standard deviations more beta than the average person your own age. Now, this is something to write down in your notes. The marker for clinical significance in terms of standard deviations is 1.64 standard deviations on either side of the norm, and some people think 1.96. What I'm really telling you is that once you get to about 2 standard deviations is where it gets interesting. But between that, 2 to 2 on either side of that spectrum, largely neurotypical, right? We don't have to get super excited unless we're digging for something that's not making itself apparent. So that top row, that all makes sense, right? This is how this person ranks relative to other people their own age who are healthy. Now, what about that second row? In the second row, we can see that there's blue in the delta, there's blue in the beta, and there's blue in the high beta. What does that mean? That means that this person is spending, if you divide it into time, or you think about how are they spending their time, even though they're making higher amplitudes of delta and higher amplitudes of beta, when we see how they hang, how they spend their time, what it's saying is they're creating far less beta and far less delta than theta. Theta takes the cake for this individual, even though their beta numbers are above average. When we compare it to how much they do theta, they do way less delta. I'm going to return to that concept. I'll plug it in a couple different times. I like to describe relative power as how you spend your time.
Okay, so it's where your brain's at, basically, in comparison to beta, this person has so much more, but alpha, that's interesting. Okay.
Right, so if we broke it into 100% of your time, for instance, right, what we would say is they're spending 75% of their time doing theta and far less of their time doing delta and doing beta or high beta, right? Right. The bigness of their theta totally trumps the bigness of their delta and the bigness of their beta.
So would that map, would it look at whatever the, like in that case it was theta that was
Yeah.
consuming it, but what if somebody was spending most of their time in delta, would that automatically show that?
Then relative power would be trumping. And so the top row could be, just pretend for a moment that it's blue, that they are just a low voltage individual. Even then, of their low voltageness, chances are they're spending more time doing one thing than the other. Or if they're incredibly high voltage. So in this case we have, with the exception of high beta, we have a very high voltage person. Their brain waves from delta up to beta are bigger, right? The amplitude of their brain waves is bigger than the average person their own age. But of that, they're spending the least amount of time doing delta, doing beta, and doing high beta. Or that is to say, the bigness of those frequencies is less than the bigness of the theta and of the alpha. Relative power comes into play and becomes interesting when we have to get more nuanced in terms of our perspective of the person. And so when someone is wildly deviant on one side or the other in terms of high voltage or low voltage, especially relative power becomes very interesting.
It's just compared to themselves, right? So in relative power, you're not comparing it to the age or to the normal database. You're just comparing it to
Absolutely.
the person
Yep.
an individual comparison.
Right, right, yep.
Do you know how stable that is? Like if you measured somebody today and next week, would you, I mean, assuming you don't
Yeah,
do
it's
any
a great
intervention.
question. So the question is, how much does it change? Barring significant events and insults, we're really very much the same. We do change throughout development. So we change as we grow into an adult, and then we change as we turn into an old person. But besides that, we're fairly stable. But you'll see with this work that people do change.
So,
Well, I'm wondering, like, you know, if you're doing this and you see something abnormal that you want to target for treatment, you have confidence that it's actually something that is a target for treatment, not something that's just kind of like they had a bad week or something.
Right. Yeah, no. Yeah. So absolutely, and as to your question, I'm confident. And part of this game is going to be detecting what's not real, figuring out with the naked eye and with maps what's not real, because there's false positives in a lot of places. But if the brain were that malleable, with the exception of circadian rhythms, I don't think that. Yeah. So no, the brain doesn't change much.
Okay.
Yeah, unless you push it to change.
Have you seen like people who are master meditators? They have like a lot more alpha.
So we'll get into it. Yeah, for sure. Meditation is an entirely different lecture, but yeah, there's so many profiles for meditation.
Brandon changed it with the exception of what he said before, the person is taking medication or not, this would be different.
So the medications that are the most, the medication that is the most impactful with the EEG is a GABAergic medication, which is things like a benzodiazepine, medications that are going to enhance the amount of inhibitory neurotransmitters. And you will see a shift in the EEG. It will start to produce more high amplitude beta 2 and beta 1, even into beta 3. But generally beta 1 and 2. When you have 2 or more medications on board that are psychotropic, then you have a synergistic effect between the two, which is unpredictable. And so when someone has more than 2 or more medications on board, it's more difficult to see how those are affecting the EEG. One blend that's a real crappy blend is a blend of sedatives and hypnotics that will slow somebody down significantly. And so you can make an idea, a guess about what different medication classes will do. I've explained the one that's the most noticeable with the naked eye, but sedatives and hypnotics will largely slow the person down. And when I say slow the person down, it will slow down their peak frequency, but it will also increase the amplitude of slow waves. A stimulant, like an Adderall or a Vyvanse or anything like that, will generally enhance the amount of fast frequencies. So that's an aside. This is a 17-year-old athlete who's had a series of concussions. And so what she's showing is, oh yeah, the gray matter, the bark of the brain in those accidents. She's a water polo player, right? There's these bony ridges within the inside of the skull that are the sutures where the bones come together, and it's not a friendly place. And so if the brain happens to get sloshed back and forth, it will scrape up against those bony sutures and create head injury. And in my opinion, what's happening with theta and delta is because these are frequencies that are responsible for neurogenesis and for neurodevelopment and angiogenesis, it's almost as though the emergency trucks of the EEG are coming to the individual to say, clear the roads, let's do some repair work, right? And very often what you'll see is when somebody who has a head injury closes their eyes, the amplitude of the slow frequencies will magnify. It will get bigger, and it's almost as though their system is saying, oh boy, they're going to sleep. Time to get to work. Time to do our reparative work. Now, in the case of a head injury that has a lingering functional deficit associated with it, it's like the emergency trucks never left the front driveway. And so there's or the street outside the front of the house. So there's a traffic jam, and it's just preventing the moving on. Right, so that's our job. Once the brain has done its own work after a head injury, which is a minimum of 6 weeks post-head injury, depending on the severity, then we can start to move some of the slow waves out of the way. All right, so alpha. Alpha is 9 to 12 hertz or 9 to 12 oscillations per second. Now, you know that theta and delta are both frequencies of the unconscious and frequencies of childhood, in large part. Alpha is the first conscious frequency. Alpha is something that we show when we close our eyes. So chances are good, if you close your eyes right now, you'll begin to produce an alpha frequency in the back of your head. It emanates from the posterior cingulate cortex. That is the alpha generator, although alpha, like theta, is thalamocortical in origin. Alpha is akin to our processing rate. So I've referenced alpha peak. Alpha peak is also called posterior dominant rhythm, PDR, in the neurological world. What that indicates is how many times per second your thalamus gates, your thalamus opens and closes. Now, if you're at a 9, your alpha peak frequency is 9 hertz. If you're at a 10, your alpha peak frequency is a 10 hertz. In this case, this person's alpha peak frequency is an 11 hertz. Now, one thing to point out, you can see why that's 11, right? The very tippity tip of the point is at 11 hertz exactly. But there are sides, right, to that 11. One side stops right around 12. One side stops right around 9. That peak, the belling of it is called kurtosis, Kurtosis. It's an important thing to know of because what it says is that the brain doesn't operate or doesn't oscillate like a metronome. We're not machines. So you're not going to get a perfect rhythm out of the brain. If you get a perfect rhythm, like a straight up 16 hertz, you have a false positive. You have an artifact in the data. We expect to see size to every peak. That indicates that you have a real rhythm in the brain, that you have a real frequency in the brain. What it really translates to is, sure, I make an 11 hertz most of the time, but sometimes I make a 12, sometimes I make a 9, sometimes I make a 10.7, sometimes I make an 11.2. And so there's a degree of variability that's reliable, right? A reliable variability within the brain. Alpha peak frequency is someone's processing rate, and so in a very simplistic sense, it's thought about as your IQ. How quickly can you download info? How quickly can you upload info? Right? When someone has a fast alpha peak frequency, they can generally put things together very quickly. A fast peak frequency is generally a good thing, but when you start to oscillate too fast, 13 hertz plus, it can be quite disturbing for the mind, because then you have the ability to pull together information in an associational way, generally, that can be a little crazy. And so it's not always the case. I mean, generally, in and of itself, in a neutral sense, a fast alpha peak is cool, but it can predispose somebody towards psychosis, delusional thinking, the ability to patch too much information together in a way that nobody else is going to understand. Yeah, a full-on mania. And so if someone has a fast alpha peak frequency and they're given a drug like a benzo that speeds them up even more, you could see them spiral into something that's kind of scary. In a similar way, alpha peak frequency, if it's slow, it's someone that might come across as a dullard, someone that's a plodder who can't just, get up and going. Now, there are silver linings everywhere, and that's the next stage of this lecture. That's not going to happen now. Right now, what I want to give you is the clear, cut and dry, black and white, empirical side of things. But alpha, when you close your eyes, you are going internal, right? So generally, you were closing your eyes a moment ago. Unless you're a very auditory person, when we close our eyes, our focus is going inside. You're not paying attention to all the external stimuli. You're going inside, and that might be internal stimuli. It might be, oh my gosh, I can't believe that he said that to me, blah, blah, blah. Or I need to go to the laundromat, and I need to pick up the kids, and I have so much to do, and da, da, da. So, but often that internal orientation is chill. And so one of the basic vanilla profiles in meditators is high amplitude alpha, right? Being in the zone, being in the flow, being present, being here and now, right? And so when you hear about flow hacking or flow states, we're generally speaking about this alpha theta range, where you're in this trancy or present mindedness sort of space of being.
And you said that's high alpha?
High amplitude alpha is internal orientation. Low amplitude alpha, when you close your eyes, if you have a low amplitude alpha, it means that there's still a part of you that's scanning the external realm around you.
And then which one did you say that could lead to people becoming like psychotic?
When alpha goes very fast, like 13, 14, that's when it starts to, it's very difficult to maintain stability.
How high it is different than
how fast it is. Yep, and that's one of the big pieces of this lecture is size and speed. They get confused a lot when people say, oh, my alpha's too fast as opposed to too big. Let me say, well, I think it's actually coming up here. Yeah. So I know you're all going to take a second and write this stuff down, but when alpha, generally actually at the end.
This is getting recorded. Tiff, would you be willing to share these slides?
I'm sharing the lecture.
Okay.
Yeah, I can share the slides too, it's fine. And so when alpha is showing up at the anterior cingulate cortex, right, which is this high density network node in the front of the brain, like Los Angeles on the airport map, it indicates there's an internal orientation, right? But that part of the brain is also responsible for error detection and processing, which says, did I lock the door? Do I have my keys? Did I shut off the water? All those pieces. And for most of us, it's just a simple, yep, moving along. When we see excessive alpha running around in the anterior cingulate, it can cause a disruption in the air processing network and an internal orientation from alpha, which can turn into, gotta wash my hands, did I lock the door? I don't know, I gotta go check it, leave, did I check it? I'm not sure if I checked it. Did I check it? Did I accidentally unlock it when I checked it? And so it's one of the markers. If you see alpha showing up back here at the posterior temporal lobe on the right, you're seeing it at T6, and that is a trauma marker. There's a longer story as to why that happens, but without getting into neuroanatomy, there's something called an affective perceptual loop that ties in that part of the brain, and when you see alpha gating, and when I say gating, I mean persistent or on at that part of the brain, it's that part of the brain saying, game over, I don't want to play anymore, right? I'm just going to make this alpha, and then I don't have to deal with the rest of the world. So in cases of soldiers or people that have been exposed to really traumatic things, it's one of the forms of dissociation. Okay? So in a very neutral sense, temporal lobe alpha, be it left or right, right? And the temporals are these big chunky things on the side, is a form of frontal lobe disengagement. I'm not hanging out, right? Because alpha is an internal orientation. I'm not gonna pull any external stimuli. T6, that is the marker of traumatic experience, and so gating
Is that
alpha.
emotionally traumatic or physically traumatic? Or
It could, yeah. I mean, I guess the answer that I would give is more of like an emotionally traumatic, but there could be a physical trauma with the emotional trauma. Generally, if there's a physical trauma, and emotional trauma goes with it.
PTSD.
Well, some people, some head injury people who are in a car accident, they don't remember
Good
the car
point.
accident.
Yeah.
So they don't really have the trauma, but they have a major head injury.
Right, and so in that case, I wouldn't expect to see it. I would expect, unless they got hit at T6, and no, even then, we wouldn't see alpha. So I guess I would indicate, you see it more in
Emotional.
soldiers that have sustained a series of emotional insults.
Same with a lot of
Sexual
sexual abuse.
abuse, right? So that's an
Severe
emotional.
And one thing, working with alpha, when you see, I guess that low alpha, like trauma,
About it, yeah. So let me keep going on with alpha for a little bit. One of the things that Mary just mentioned is what's called alpha blocking, right? And so, so if you think of the realms of theta and delta as realms of the unconscious, if we apply a psychodynamic lens to that, which is where we're going to go, they're realms that hold our own stuff. Alpha is a frequency that allows for an integration. You wake up, you produce alpha. You let your brain relax, you produce alpha. It is a bridge between frequencies of thinking and of cognitive processing and frequencies of being asleep and being super chill. And so alpha is a bridge that allows for individuation, integration, self-actualization. When there's a bottleneck on that alpha frequency, it's like a white knuckling, right? So when someone doesn't produce alpha when they close their eyes, it's like their system is saying, oh no, I'm not going to relax. I'm not going to let down. I don't know where the boogeyman is, and I'm not going to allow myself to become unguarded because something might come and hurt me, right? So alpha blocking is a trauma marker.
So that's the superego in Freud's model?
Well, the superego is a moralizing force in Freud's model, so no. But it's simply an inability to connect the two realms of the unconscious or my own internal stuff and the external. Okay. And so low alpha can indicate a lack of self-regulation, poor sleep, and anxiety. Again, if we draw on this notion, and again, alpha here is the adjective of chill, flow, being in the zone, being present, right? So if you don't have that, there's generally going to be a little bit more agitation and inability to calm oneself, similar to theta in that regard.
you see a lot of excessive alpha when you do an QEEG on somebody who's really stoned. I've seen that too. I mean, because again, they're just really chill.
So
Yeah.
so THC has the effect of amplifying alpha's amplitude, and in that same sort of vein, if someone just has a lot of eyes open alpha, not eyes closed but eyes open, they're in the zone, in the flow here and now present. But think about a stoner, think about someone who's chronic, right? Like they're going to be producing high amplitudes of alpha. But even if someone's not, if they're producing a high amplitude alpha, they're generally going to be here and now, but they might not be able to like prioritize, get the homework done, concentrate, focus, sequence tasks, things like that. If somebody, if someone starts to fall asleep within 1 minute, which starts with high amplitude alpha and then alpha goes away, then they probably have apnea, or if they have a lot of eyes open alpha, they also may have a sleeping disorder, and it's their system saying, I'm exhausted and I just want to fall asleep.
When you have frontal asymmetrical alpha and you say depression, is there a particular side, left or right, or
No,
just
I don't
the
believe
difference?
so. It's a good question. It's a Yuri Kropotov answer.
Can you clarify what is asymmetrical?
The right side, the right side,
Is it per-
most of us are most of us are right-handed, and so the left side has generally a little bit higher amplitude alpha. I can't remember, one side was a little bit higher than the other. So a certain degree of asymmetry is allowed, which is a roughly 35% asymmetry. But that alpha asymmetry profile, generally frontal alpha, is this marker of depression.
I think you have more right side. Generally, if people with depression, they have a lot more on the right side.
A lot higher amplitude alpha on the
Yeah.
right side. I think it's a fact. This is such a good question, and I just wrote about it. I think it's a factor of double, where it becomes really significant when alpha on one side is double the size of alpha on the other. And I find as well a dual peak alpha. So when someone has two alpha peaks or two alpha frequencies, that's indicative of depression as well.
And is that localized when you say the dual peak, the one hemisphere versus the other, or
No,
just simply saying
just
that
two
the waveform
frequencies.
itself is double?
Yeah.
I just want to clarify the asymmetry.
Yep.
Is it related to the amplitude or to frequency?
Yes.
Okay.
Amplitude. Yeah, so if one side is higher amplitude than the other side. This is totally a good slide to take a picture of. And so let me explain what this is saying. As we get older, from the time that we're born until we're roughly 10 years old, but honestly 10 to 15, especially for boys are later than girls, our alpha peak frequency speeds up, right? And so when we are 4 months old, our alpha peak is a 4. That's our processing rate. That's the gating rhythm of the thalamus. That is alpha, even though it's in the delta range, right? So this is developmental neurology, right? This is pediatric neurology.
So how do you know that it's alpha if it is not?
Because it's sinusoidal, and that's when we get into morphology. And this is where EEG becomes really beautiful. It's like tea leaves. It's a very it's very interesting to look at bumps and to say, ooh, this bump means this. So when we hit 12 months, when we're 1 year old, our alpha should be at a 6. By the time we're 3 years old, our alpha should be at an 8. So you can see that alpha peak frequency. We're taking in more information. We're becoming faster processors. By the time we're 9 years old, we're usually at about a 9. And by the time we're 10, 11, 12, somewhere within that range, we're usually at about 10 hertz. So it's interesting because you don't mature into a 9 hertz alpha until you're roughly 9 years of age. At 9 years of age is when you start to get hit to the fact that Santa Claus isn't real. 9, 10. It's when you're like, yeah, is that tooth fairy really real? And so it's interesting because the ego is coming on all along, right, throughout early life. But it's when we transition into 3rd and 4th grade that childhood anxieties and fears of mortality, at least I found, become a little bit more prevalent. Like, mommy and daddy are going to die. The magic of childhood starts to wear off a little bit, and that's when our alpha peak matures, and we move out of the fantastical, imaginative realm of childhood. So we solidify to our mature alpha peak when we're roughly 10 years old, and then as you get older, when you get into your late 50s, early 60s, depending on a lot of different factors, but generally we start to slow down just a bit, right? The apex is right around 25 years old, but who knows if that's really
Downhill
true.
from there.
It all sucks after that. That's when Einstein wrote all of his papers. 1905 is when he was 25. Yeah. So abnormal. And this is really important when you get a pediatric case that comes to your clinic. You've got to be able to find their alpha rhythm. Because then you can say, okay, well, even though the EEG looks crazy, because little kids' EEGs look like little kids' handwriting, it's a ton of theta. The raw EEG is like blah, 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 because they are a kid and their brains are coming into formation. But their alpha peak, if it's at, beneath these frequencies, then you have someone that's slower than average. The 8 hertz in adults is less than 1%. If you have an 8 hertz alpha peak frequency in somebody, to be a scientist and an empiricist and a astute clinician out the gate, you have to question their processing speed and whether any of their issues are related to that. But there's a whole silver lining to a slow alpha peak, and I'll just leave it there like that. Yeah, so alpha is constant throughout life, and then it slowly declines just a little bit with age. Okay? So Jorge was asking about how do you know if it's that frequency, if it's alpha versus theta. And so, for instance, right here, what we have is a nice sinusoidal diphasic alpha. Sinusoidal because we have the same shape, diphasic rather, because we have the same shape on either side of the baseline, meaning 2. Diphasic, biphasic, synonymous terms. Sinusoidal meaning it's like a smooth S, like a sine wave, right? Alpha is sinusoidal. That's the shape of alpha. There's other sinusoidal frequencies, but that's how you recognize alpha. So in this case, it says not theta but slow alpha, and if we count, we can see, and I'm going to go here, 1, 2, 3, 4, 5, 6, 7, 8. Okay. This
I
is.
thought it was 9 to 12. Alpha.
It is. So it's a slowed alpha, right? Because it's alpha shape. This is where morphology comes into play. So it's tricky, and I'm giving you a download of advanced EEG woven into basic EEG altogether. Okay, so hang on to what you can hang on to and keep what you want to keep. Alpha blocking is going to look like this in a map, right? And so what we have is
I just wanted to add something to that.
please.
So something to hold, or like 8 to 12, I mean, that's like a normative range, and you can see alpha 6, 7, 8, 7.5 hertz, and you can also see it 13 hertz, 14 hertz. And when you look at these flat maps, like Tip has up on here, these things are assuming these ranges. So yeah, learning how to look at the raw EEG and determining like what am I actually looking at, where's it coming from? I mean, that's beyond what we're getting into now, but will really help when you look at these flat maps to know what you're looking at. Because you could look at it and someone would have 13 hertz alpha and the beta is going to show up here as bright red. But it's not beta, it's just fast alpha.
And so that's the fast Fourier transform, right? And that's why in the beginning I was saying the seminal text and the translation. The fast Fourier is just saying, I'm seeing wavelets of this speed at this size. Doesn't care what shape it is. Anyway, I digress. Alpha blocking is going to look like blue alpha. This is a little girl with nightmares, right? She closes her eyes. She does not relax. She white knuckles it. She does not let go, right? There's a stress. This is a pattern of stress. This is one sign of a trauma. But it doesn't necessarily have to be a trauma. It just means that they're having a very hard time relaxing. Trauma marker alpha is a gating or a persistent alpha at T6. That's what it looks like. And again, I've shifted to a focal montage, the Laplacian montage, which you can see right up here. And that's what it's going to translate to in a map, right? So although it's 8 hertz, it's in the alpha range because it's sinusoidal, right? And it's showing up right there at T6. So that's how the raw translates into the map. So beta. Everybody in this room right now is in beta. I'd put $1 million down on it unless somebody's sleeping that I can't see. Beta is a frequency of 12 to 30 hertz. Okay, Beta 1 is 12 to 15. Beta 2 is 15 to 19. Beta 3 is 19 to 25, and high beta is 25 to 30. Beta is a frequency of active conscious cognitive processing.
Sorry, it's B3 is 19 to 35?
B3 is 19 to 25. HB, high beta, is 25 to 30. Beta is being mental, mentative, thinking, logic, planning, reasoning, doing things with your mind, right? Beta is a cortical frequency. It's a hyphenated term, cortico, hyphen, cortical, and what that means is that it's born of the bark of the brain, and the 6 layers of pyramidal neurons that create the cortex. Cortex is a Latin word for bark. And so beta, unlike delta, remember how I was saying delta makes this long trek across lobes? Well, beta is a focal or a pattern, a frequency that likes to live in tiny little neuronal pools. So beta likes to hang out in its own little hood, right? Beta facilitates local communications. These slower frequencies of delta and theta, those serve as carrier waves on which faster frequencies ride, which is why when you look at the EEG and you're like, I can't read that, it's because you're seeing like 4 frequencies at once. You're seeing delta, on top of that maybe some theta bumps, and then some little beta spikes, right? But beta's local. Unhealthy beta, a deficit of beta, can indicate a GABA A receptor mutation, an addictive personality type, but I guess in a very simplistic way, low brain power, right? Like the way that we consider brain, like not somebody that can really rally their cognitive capabilities easily. And they may also have attention or focus problems, okay? Beta is, because beta is the realm of thought, beta is the realm of the ego, but ego in a pejorative sense. So beta is where neuroses live, right? Stress, anxiety, worry, fear, dread, doubt, agitation, increased intensity of emotions. Beta issues are some of the easiest issues to address with their equipment because it's directly underneath the electrodes. It's directly underneath the skull. It's directly underneath these different meninges because it's cortical. And so when people come in with an anxiety disorder, stress, panic attacks, things like that, I tell them you are our low-hanging fruit, and generally we can see a pretty radical change in a number of sessions. Here's one simple profile of stress: central spindling beta. It's central because it's at CZ. C stands for central, Z stands for zenith. So frontal zenith, central zenith, parietal zenith. CZ is the tippity top of your head. You have no muscles up there. So if you put your fingers at the top of your head and try to flex your muscles, you got nothing. The good news about that is that you're not going to get muscle artifact at the top of your head. There's no way to get fake beta up there. A central spindling beta is going to create a map that looks something like that. Of course, there's some temporal beta there as well. That is a central nervous system over-arousal in a very basic sense, but it's also a wakefulness drive. When somebody has that profile, chances are good they don't sleep very well. It's one flavor of stress. This is an old slide. This is a before and after of someone that had some anger issues, and that's how it manifested in their EEG. So, is that ventrolateral prefrontal beta. Our job, as the week progresses, you're going to leave with information, but hopefully for the desire for more. And our job is going to be to align symptoms and findings. So when someone comes in and they say, I'm dealing with this and this and this and this and this, my job is to find those things in their EEG. Where do they live? How do they manifest? Okay, a few more slides here. Cool. So gamma. Gamma is a frequency that is beyond 30 hertz, but gamma's favorite domain is in the 40s, maybe in the 50s. somebody's gamma, your ideal gamma is generally going to be the fourth harmonic of your alpha. What does that mean? That means that if I have an 11 hertz alpha, my gamma is going to be roughly a 44. You need me, Johnny, or you just Liam? Okay. If I have a 9 hertz alpha, my gamma is probably going to be about a 45. The gamma that my brain likes the best, because it's a harmonic of that alpha. A 40 hertz gamma would correspond nicely with a 10 hertz alpha, right? 10 being the common denominator of 40. And so unlike other frequencies, gamma does not have a generator. There's not one structure in the brain that makes gamma. Gamma is an emergent property in the EEG, which means that it arises from a state of criticality. And that state of criticality comes about when slow cortical potentials come into a synchronization. And gamma is the resonant property of the network being bound. Right? So what that means is when we have, think about a square with 4 dots. When that square synchronizes and it goes, yeah, like it lights up, as people would say in a book, for instance, then we would have gamma show up for that moment in time, right? As a byproduct of a network being bound. Gamma's a good thing. When gamma comes on, it comes on in bursts, or it comes on in chirps, which are, aha, eureka, I got it, right? That's generally what happens when gamma bursts on. It's a recognition of novelty. Like all other things, there are silver linings to gamma. This is in this map we see what looks like a persistent gamma, right? It seems to be fairly constant, although it goes boom, boom, boom. You can kind of see that at the top where it gets loud, loud, loud. And then in this, because a normative database can't track gamma, because gamma's easily confused with muscle artifact. And so I don't know if there is a normative database that has a normal level of gamma. What we have to do is look at the raw numbers. And when you see a raw number in the gamma range pop up, as opposed to going down, 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 if it pops up significantly, like here we see a 1200 microvolt squared, right prefrontal, has high amplitude gamma showing up there. This is an individual who's an active channel. And so it's a channeler of spirits. And this is someone who's showing this incredible amount of gamma in his prefrontal. Unhealthy gamma. Unhealthy gamma is persistent gamma or tonic gamma. I call it car horn gamma. I think of it as like when a car horn is broken and it's like, and it's just blaring. Right? We don't like that. What that indicates is that a network is seized, it's bound, and it's not letting go. Or it could indicate that there's a demyelination disorder of some sort. Demyelination, of course, is the breakdown then of the oligodendrocyte glial cells that create the myelin sheath that runs along the axon. And that can create, depending on where you see it, different types of disorders. This gamma that you're seeing there, that is the gamma of an easily kindled cortex. And so an easily kindled cortex is like an irritated cortex. And an irritated cortex may be inflamed, in which case you might see beta as well. But you also see it in seizure disorders, right? And so I think of it as like someone that gets so upset that they just pop, right? And so it's that building of tension that is the kindling. Or think about the beginning of a fire when you're hearing snaps and pops, right? That kindling is then kicking off a slow wave. Now in this case, nothing fantastic has happened, thank God. But in the case of like a myoclonic tonic seizure, you might see a kindling and then a kickoff into a slow waveform that's so loud that it synchronizes the entire EEG for a moment. That is an image of what a thalamocortical dysrhythmia looks like. And that's a term that if you get into the neuro world, you'll become familiar with it. It's a clinical presentation. What it means is that the slow gamma, right, in this case we're seeing it at roughly 47, also at 40 hertz because we have kurtosis with the waveform. It's riding on alpha at 10. And usually a thalamocortical frequency is going to ride on slow frequencies. Think about a roller coaster, and that's the actual rails are the slow frequency, that's the carrier wave, and then the faster is like little passengers in the roller coaster. And so a thalamocortical dysrhythmia is a persistent gamma coupled with a slower frequency. I'm sure that I'm inundating you at this point, but just to cap off the thought, if you see it in the anterior cingulate cortex, it is one form of attention deficit disorder. If you see it in the central cingulate, it can be linked to depressive disorders. If you see it over the sensory motor strip, it can be a movement disorder, tremors, things like that. If you see it in the temporal lobes, it's generally a hearing disorder like tinnitus, misophonia, or hyperacusis. And so there's lots of ways that thalamocortical dysrhythmias can manifest. This is a program called MATLAB, and I'm running you right down to the rabbit hole, down the bottom of the rabbit hole, because we're getting into an advanced form of computational neuroanalysis, but it's certainly something to aim for. Okay, to top it off, let's talk about connectivity indicators. We've covered power now, and we've covered frequencies. So, I don't like this map, to be honest, for a lot of reasons, but I'm just going to work with it because it could be a shitty reference. But what we have is you're drawn to all the connectivity in all the coherence across the board, right? So without me second guessing the recording itself, let's just talk about what this might mean.
So we're on the 4th row.
Yep, the 4th row down. Yep. And what red in coherence means is hyper coherence. Coherence is the stability of the phase relationship between different sites in the brain. That's a formal definition.
That's a great way to explain
Great.
that it's
Stability of the phase relationships between different sites in the brain. What does that mean? The keywords that I like to pull out there are stable relationship, okay? And so when you have a stable relationship with your partner, you come home at the end of the day. They might have had a good day, you might have had a good day, or you might have had bad days, who knows? But there's a stable relationship. You can make dinner and kick it, and it's fine. You might go to bed at 10, you might go to bed at 11:30, whatever. There's a stability there, right? It's reliable. An unstable relationship would be one where we have, let's talk about it from the perspective of coherence. Let's say you had a hypercoherent relationship, so a relationship that was overly stable. In this case, what we have is like a metronome brain. Everything is coming into lockstep. We've got soldiers goose-stepping, right? What happens when soldiers goose-step across a bridge? They destroy it, right? But that means that you are home at 5:30. It is dinner and it's Wednesday, and that means that we're having tuna fish sandwiches at 6:15 p.m. on the dot, right? So think about hypercoherences as a form of rigidity. Now that rigidity means that we have a synchronization of frequency. Hypercoherence in delta is delta synchrony or hypersynchrony. Hypercoherence in theta is hypersynchrony in that frequency. And so what you have to do is apply the adjective of the frequency to the modality of overconnectivity. Hypercoherence in beta. What are we dealing with beta? We're dealing with mind. We're dealing with thought. We're dealing with neuroses. A hyperconnectivity in beta would be a inability to transition from one task to another. It would be a kind of a locked-in freneticism. In a very neutral sense, that person might be able to bullet through some work really, really well with a laser-like focus. But they also may be very rigid. They might be, just kind of ruminative, perseverative, fixed, overly focused. A hypercoherence in a theta. Now you've got a locked trance. There she is. Welcome, all the way from LAX, right? Ah, what an adventure it's been for you. We're squeezing in, so find yourself a spot. So think about that same principle and apply it to a slower frequency like theta. Then we have a lock in theta. That's a little bit more like a trancey lock, right? But it's still a rigidity, right? So it's an over synchronization. The opposite. Let's go blue. I wonder if I have a blue map in here. No, I don't. So if those coherences were blue, now I've told you what a hypercoherent person would look like. A hypocoherent. That would mean that you get home and you and your wife have had good days or bad days. Let's say she had a bad day and she's throwing vases across the room and she lights the house on fire, or she, whatever. You get the picture. And so a hypocoherent brain is like, if hypercoherent is Bach, right? Hypocoherent is like a 7th grade jazz band. I mean, just cacophony, right? Just bad. And so there's no rhythm, there's no reliability, there's nothing that's synchronizing. It's a cacophony. You apply that frame of mind to the different frequencies. What would hypocoherent beta be like? It would be like you can't get anything done. You can't lock into task. You're in 1,000 different directions. You're oscillating at this speed, at that size. Like there's an inability to come into a coherent fill in the blank when you have a hypocoherence. A hypocoherent delta, hypocoherent theta would say to me that the slower frequencies that are the interlobule frequencies of delta and theta aren't doing their job. And so that would make everything beyond that much harder to do, since that's the fundamentals of how EEG is operating in the brain, from the limbic structures and the reptilian structures of the brain. I don't spend a lot of time on asymmetry. Yeah.
That was quick.
Goodbye.
Very quick.
Forget about it. Asymmetry is going to be reflective of a power differential in the brain. And so let me just back out here and show a map. So here, look at this map right here on the right-hand side. Now, you see in asymmetry, right, the row of amplitude asymmetry in the 2 columns of beta.
Mm-hmm.
You see that little star coming out of the corner, that little spot of asymmetry? What that is telling us is that T5, or that left posterior temporal lobe, is louder than the other sites in the brain. He is asymmetrical to the other sites in the brain. That's helpful, but we can already tell that from the power map, can't we?
Mm-hmm.
Right. And so the colors in asymmetry are reflective of the direction of the asymmetry, which is not very helpful, because you don't know which electrode is A and which electrode is B. So you have to ignore the colors in asymmetry in a neuroguide format.
I didn't follow, so can
Yeah.
you repeat
So-
that?
So the directional part,
So what do we have on the left and what do we have on the right? Is that what you're referring
no,
to?
let's. I'm just trying to pull
Oh.
up an example of asymmetry. So let's look at these 2 heads. What I'm saying is, this and this. What's that? What's that all about? Is that a bad thing? No. What that's telling us is what we can already see right here. That this spot is asymmetrical to the other sites in the brain. So asymmetries will largely reflect a deviance in symmetry that we can generally see in a power differential with our naked eye. Yeah. Okay. So we've talked about coherence. Last but not least is phase lag. So there's a lot of words on this slide, which is not my style. So take a second to read it, and then I'll start to talk. I'm going to be done here in just.
I have to go to a meeting now.
Oh, really? Okay. All right. So now that you've read that, I'm going to give you an analogy to sort of throw it into. There's a whole dynamic called phase reset. Pen. Ha. So let's say that we have one EEG electrode, right? And then we have another EEG electrode. Okay? And so this whole pen. Oh, well. Oh. So that whole dynamic, right? Up until this point, we have synchrony, right? We have phase lock. We have what's called phase lock, right? Two action potentials coming into synchrony, and then over here we have what's called phase shift. Okay, where they're not in lock, when they're out of lock, right? So that whole dynamic is called phase reset. Okay, now every 200 milliseconds or so, we see an entire phase reset of the EEG. And what's happening when we have phase lock or phase synchrony is one neuron or a few neurons are saying to their posse or their neighborhood surrounding them, everybody come and do this dance. And so everybody gets together, they do this one particular way of being, they all get together, and then they shift, and they all break up, and they all go about and do their own things again. So it's synchronization, asynchronization, synchronization, asynchronization. That's been correlated with intelligence. And so I like to think of phase lock when it's deviant, when it's too locked, right? It's almost like a dictatorship, where everybody has to wear gray, if you think about like North Korea or something. And everybody has to behave in a certain way. And so that's too much phase synchronization. Neurons don't get to break away and call on other people to do the same thing. Phase shift is like anarchy, right? It's like nobody's cohering whatsoever. It's a very similar thing to coherence, right? Now, when you have too much phase lock, you don't have enough phase lag. Now I'm just going to start to explain this to you in semantics so you can understand this measure. So, phase lag, right? Phase lag is like this phase shift, right? When we have blue phase lag, it is hypo phase lag, not enough phase lag. Hypo phase lag equals too much phase lock. Right? So it's a little like, it's like you have to translate it. You look at the blue lines in phase lag, you say too much phase lag, or excuse me, not hypo equals not enough phase lag. Not enough phase lag means too much phase lock. Too much phase lock equals dictatorship.
So hyper phase lag is like phase shift. It's
And
constant
hyper
during
phase lag is
constant,
like phase shift.
and you see with ADD,
Yeah, so
that's
hyper
phase
phase
shift.
lag, red phase lag is too much lag. Anarchy, very similar to hypocoherence, right? So the blue phase is like the red coherence, and the red phase is like the blue coherence.
Is it possible to have like a lot of phase lag, but also have a lot of coherence where the brain is just locked in a pattern where they're not cohering with each other, but still but having that like cosine sine kind of relationship? Or is that just it's just not possible?
So I'm going to pause here for the second. So for this last piece, when the voltage of the EEG is low, so the beta is blue, or the theta is blue, or the alpha is blue, or whatever, coherences in phase metrics are not significant. Because with microvolt squared, we're looking at something called 1 over f, and when essentially you're comparing teeny weeny and teeny weeny, how they cohere is irrelevant, right? It's not an important metric. Coherence loses its power in terms of how important it is when the voltage is low in that frequency. Okay. All right, now we are officially at the end. Thanks for hanging in.